My name is Christian Scharenberg. I am a hematologist based in Skövde, Sweden, and I have previously worked on CHIP and MDS, and I am here today to talk to Kirsten Gronbaek, who is an expert on CHIP and MDS. Kirsten, could you introduce yourself?
Yes, so I'm Kirsten Gronbaek. I'm a professor of hematology in Copenhagen, and actually I'm a physician scientist, so I work both in the clinics and I have a research lab where we work on CHIP and MDS and a little bit on lymphoma.
Yeah. Could you define CHIP for us?
Yeah, so CHIP is called clonal hematopoiesis of indeterminate potential, and it signifies that there are somatic mutations in the hematopoietic stem cells. There has to be more than 2% variant allele frequency in order to call it CHIP. And CHIP has been associated with a lot of AIDS-related disorders, in particular hematological cancers, where it's about 10 times increased risk of hematological cancers.
What's the frequency of CHIP in the general population?
Well, if we use very sensitive methods, these clones can actually be detected in all of us.
Yeah.
But there is this cutoff to say 2% variant allele frequency. And by the age of 60, around 10% of us has these clones. But if you go to the age of 100, it'll be about 40%. So the incidence is increasing very much with age.
And if I remember correctly, the standard 70-year-old person has like 350 or 400 mutations that can be detected, right?
Yeah,
right?
You can detect, but of course,
Only
not very many of them they make big clones, because it also is about the fitness of these mutations in the cells.
Sure, yeah. Sure. There's a phrase being thrown around that's called epigenetic age. Could you define that for us?
Yeah. So epigenetic age is actually like a biomarker of aging, and it's based on DNA methylation on blood cells, in blood cells, and you can have an accelerated epigenetic age if the methylation profile of your blood cells is actually corresponding to an older chronological age than your actual age, then you have an accelerated epigenetic age.
Right.
And there are two different kinds of, because you look at, people have associated CHIP and epigenetic age. So if you have a CHIP, you have an accelerated epigenetic age. And then different types of mutations have been assigned to different types of epigenetic aging. So DNMT3A mutations are associated with what's called intrinsic epigenetic aging, this is related to the cells themselves, while you have TET2 mutations that are associated with extrinsic epigenetic age, meaning it's actually about a change in the blood cell composition. So it probably will mean that the blood cell composition has to be sort of a senescent microenvironment for the TET mutated clones to actually grow.
Is it known whether it's stroma or if it's the descendants of the original mutated clones that alters that?
It's the mutated clones, I'm pretty sure. Because we did another study. So we presented, where we published this in Hemisphere recently about something about the epigenetic clock. But we did another study where we looked at DNA methylation in CHIP, in TET2 mutated CHIP. And what we could actually see that already at the stages of CHIP, the myeloid enhancers had methylation changes that could also be found in MDS and AML, meaning that this is probably very early changes in the blood cells that might be driving towards myeloid cancer.
Is the presence of CHIP associated with a shorter survival in non-hematological disorders?
In general, CHIP is associated with a shorter survival. In non-hematological disorders, it's very variable. It depends on the disorder. I mean, CHIP has been associated to a wide range of different diseases in addition to hematological cancers. And that is now being discussed a little bit. But for example, I mean, there's been a lot of hype about cardiovascular disease.
Mm-hmm. And that was TET2, right?
Yeah, it's TET2, and they have the TET2 mouse model where you can see, there's a very nice picture of the mouse aorta full of atherosclerosis. But now, actually, there was a very recent paper based on the UK Biobank by George Vasiliou showing that where they didn't find the association to cardiovascular disease. So I think this is an open question, and it probably needs to be looked at in different populations. But most studies have shown an association. There's also a very interesting study where they treat. It's a cardiology study where they use canakinumab, which is an IL-1 beta inhibitor, and they see that that patients with TET2 mutations actually do better, so that it works better there. So I think there's certainly something, but we probably will need to look more into it. Mm-hmm. Yeah.
Mm-hmm. And are there currently treatments or treatment strategies being developed for CHIP?
There's a lot of discussion about that because you don't want to really make 10% of the population above the age of 66, right? Mm-hmm. So I think we have to be very careful with that. But I think the time has come to do clinical trials in certain situations. So, for example, we know there's a positive association with having donor CHIP and allogeneic bone marrow transplantation. So, donor CHIP with DNMT3A mutations. So that means the recipient gets more graft versus host disease and actually also have a better survival or less risk of progression.
That's very intriguing because that's probably associated with the intrinsic fitness of that clone that comes from the donor.
Yeah, or maybe actually mutated T cells is also very interesting issue, or maybe the inflammation that is created by the clone. Yeah, so that's a positive association. So it goes in all directions. But I think your time has come to do clinical trials, particularly in a situation where you also have cytopenia, those CCOS patient clone cytopenia of undetermined significance, and we are actually doing quite a few types of trials in that area. So we're doing a trial with all vitamin C, and another one with metformin, because there's the idea that the bone marrow adipose tissue is actually stimulating the clone. So that metformin. We're opening up a new trial now on how exercise affects clonal hematopoiesis. So, but of course this is in a population of patients that are referred to us to the hematological departments already, and they are more sick. And I think if we want to do something just in a situation where you have CHIP where you don't have any cytopenia, then we really need to find very non-hazardous drugs, right? So, but for example, if vitamin C really means anything, then that should be done in a big population study.
Yeah, fascinating. Thank you very much.
Thank you.